onto your screen and change your power settings somewhere. So the device can be the wearable photometer doesn't use any variable lenses. It has a couple of only two lenses, and you can sit Delhi and kind of in Orissa change the subjective power. And in case an optom is not there, we have the teleoptometry platform. The moment he selects a spectrum, pupillary distance, the nose weight, the planet optic tilt, all of these things, right? So that also is so if a hospital is not doing anything in optometry, they don't have to have this. But this is going only to an optometry clinic. They can have this, and then later on, if they decide, they can add fund or OCC. Now, and the last piece obviously is artificial intelligence, and then these are also connected to the outside ecosystem. One is the tele-eye, which we exclusively made for ophthalmologists for consulting between their patients, audio video consulting, and then it can connect to multiple spectacle vendors. We don't make spectacles, so we connect to any spectacle vendor. They can decide when they want to buy. And this is just to give you, probably one of the largest tele-optal projects in the world, I would say, which we did for Andhra Pradesh, where we supplied both the hardware and software, Apollo front end and this. So about 114 community health centers are connected real time. And you can see we have done like 2.15 million screenings, 720,000 fundus checks, 1.6 million spectacles delivered, and out of the 720, about 114 have been identified with problems. So this you can track it. This is available. Anybody can actually look at it, and you can drill down and see in which community center, in which let's say if you are looking at a particular CHC within the district, you can go down and you will know in which district so many refractive errors were there, or so many cataracts were there, or so many retinopathy was there. So the government can actually provide the last mile. Now the same thing can be done where we don't have to run it with the government. We can run it with, let's say, corporates, where we can put this and this connected to multiple doctors, and whichever doctor is nearby, the patient can go there for treatment. So we don't have any bias. We keep it very open. The patient decides whom they want to go. So if we tell them that around your region, 100 kilometers radius, these are the 10 hospitals. You decide where you want to go. So makes it very, very agnostic, makes it very, very open. The only thing we'll have to ensure is whether they went or not. Of course, I'm not saying that we have solved that, but we are slowly getting there, right? I also want to bring in Professor Hussain talk about it. So when you are screening high volume, so you reach, so the initial approach was, I want to identify who are potentially having an issue. Now, once you do that, and let's hypothetically imagine that we screen all the 6 billion or 8 billion in this world, that is going to leave with us about 80 million people who have chronic diseases, various chronic diseases. And now these people, how do you manage them? Because these are far more vulnerable than the 6-7 billion. But how are you going to manage them? Because their behaviors are very, very different. So that is where we thought a part of the whole thing could be a continuous disease management. And the disease management basically is more or less what Professor said before, but it is one single platform connecting multiple doctors without sharing data between them, right? So it is like if Dr. Subudhi has 100 diabetic retinopathy patients, he will use this platform, connect to them, and then we will go, or initially to prove we will go, but later on these devices will be available in a nearby optical store or a primary care center. So they will go there, take the image. AI will actually say that what is the change between their previous image and the current one. And then Professor Subudhi will consult them on audio video. And if he feels that there has been a deterioration, of course, it will also have some of these qualitative data. And once that is there, then he can either continue the service after 6 months, or he can actually immediately call him. Now, this is again a monetized kind of a model. So this will be a subscription between the patient and Dr. Subudhi. So there is a revenue. There is, of course, some will be shared for us going and or whoever is sharing the imaging. But then it will be lower than the cost of conveyance and the convenience what that patient has to go through to come to the hospital, right? And if they can come, so again, there is no compulsion. You can ensure if you want to go, it is cheaper, you want to see him, good. If you don't want to go, this is the way the cost matching will be more or less the same, so that it is actually a viable and scalable model rather than just a one-off model. And this will be possible only because the entire thing has to be structured and multiple users use it. And as we find problems or as we find more optimization, it will get more and more cost effective, both for the provider as well as for the patient. So again, we can keep it for many diseases, DR or dry eye or myopia. Myopia is also becoming a big problem, or glaucoma or ARMD, right? And then this will ensure that the patient is at home, right? And the doctor actually kind of manages him at home, exactly like the example what Professor had shown. But I think the best part of this is this will be a platform connecting multiple doctors. So, but for the individual doctor, it will look like if it is his home, but actually the infrastructure is spread. So the cost variation. So if Professor Subudhi has to invest in this, he'll probably spend 10 crores to do. So that means he has to charge so much to the patient. Whereas when it is shared between thousands of ophthalmologists, the cost of this becomes low. So then it becomes viable or scalable for anybody. Now, this will obviously mean that we have to, so when we build devices for hospitals. And then the same devices can go into primary care. But then when we decide that we are going to go home, then it will actually lead to certain new creation of new devices. Now, I definitely want to separate this between the first level screening, because in the first level screening, we want to rule out all the possibilities, at least at a top level. But whereas when he is a known patient, the known patient obviously will be able to, for convenience, cooperate. So it is easy for us to build products which will be miniaturized, which will probably take a little more time to, use. So for example, in a high volume CAM screening, you will have to take retinal images in 1 minute. Whereas when I go to somebody's house, I have the luxury of doing it in 5 minutes, right? He's not going to feel threatened. So we can compromise on few things, but not compromising on quality of care. That is very important, because these devices can be built, which will, whatever gaps are there can be closed when we find, when we're going for these home kind of screenings, right? And then this is the last slide. So basically, when you build this, it actually opens up several monetization models and scale, both, right? So nothing can be built on philanthropy. So even if it is 5 rupees or 10 rupees, I think that is required for sustainable growth for anyone, right? Whether it is the provider or the hospital or the doctor. So it can be individual. So you can run a teleoptometry as a separate one. You can do teleconsulting as a separate one. EMR integration will be there. Disease management as a standalone can be a product.